Alright, now this is one of the hot topics of the gastroenterology, parrot's esophagus. I want you to know that if PPI decrease the risk of emerging of parrots from GERD and erosive esophagitis, once Barrett develops, PPI have no role in reducing the cancer risk. What's the definition of parrot? Parrot is most likely it's an acquired phenomena due to the adaptation to GERD, and it's simply the replacement of the squamous epithelium of the tubular esophagus by specialized columnar epithelium. Whether there is a goblet cells, that's no longer of significance. So it's just an intestinal metaplasia of the squamous epithelium of the esophagus that occurs 1 centimeter above the transition zone or the GE junction. Here is some talk about the long segment parrot esophagus and the short segment parrot esophagus. This is nowadays have no much of significance. Actually, the surveillance is equal for both of them. They carry no much that of significance. I just want to tell you that in case the long segment means that it's more than 3 centimeters long, short segment is less than 3 centimeters long. Regarding the prevalence in the general population, the short segment occurs more than the long segment, while in the GERD people and the reverse is the long segment occurs more than the short segment. Anyway, this is, I said, if no much of significance. Just know here that with grade A and B erosive esophagitis, there's a 10% prevalence of parrots, while in C and D this doubles to 20%. Regarding the intestinal metaplasia of the cardia, we're not going to talk much about it. Just remember that you shouldn't biopsy this area here as the cardia. So the intestinal metaplasia of the cardia carries no significance. The annual risk actually have been debated in the past couple of years, but these are the numbers that you should focus on from now on. Without dysplasia, parrot without dysplasia, the annual risk is 0.2%. With low-grade dysplasia is 0.7%, and high-grade dysplasia is 7%. These numbers are important. So what are the risk factors? Usually parrot esophagus won't evolve without risk factors. The risk factors that we know now is related to GERD, anatomical changes in the GE junction, and there is a demographic issues here. So regarding the GERD, you need to know that the duration is more important than the severity and the symptoms. So long-standing GERD, talking about more than 5 years, and GERD risk factors that we know, actually these are very important risk factors, and erosive esophagitis, of course, carries a 5-fold increase. Hiatal hernia, low LES pressure, esophageal dysmotility, and sensitivity to acid, all of these predispose patients to parrot. Regarding demographic issues and the lifestyle, white people, males have double the risk. People who are older than 50 years have higher risk to develop parrots. Regarding the obesity here, it's the increase of the waist-hip ratio rather than the BMI is the risk factor. So remember, it's not the BMI, it's the truncal obesity. Here in the males it's more than 0.9 and the female more than 8. That's the waist circumference more than 2 centimeters in male and more than 88 centimeters in females. Also smoking predisposed to parrots, and family history also play a role. Other injuries to the esophagus due to bile reflux and pancreatic juice do carry a risk. Regarding the symptoms, nearly half patients do not have symptoms at all, while the other half do complain of GERD. Parrot esophagus itself decreases sensitivity to acid. That explains why there is no much symptoms with parrots. When you diagnose parrots, first of all, this image has been adopted from DDSEP for the copyright purposes. You need to focus here on how we report parrots when we do the endoscopy. So remember, this is hiatal hernia. You don't count from here. Instead, you wait until the gastric fold terminates and you start counting your parrot. This is the segment of the parrot. This is called the Bragg classification. This is the area where the most circumference of the segment here. That's C. You count it from the tip of the folds until it terminates here. And the M is the maximum. You count it again from the tip of the folds, not from the circumference, and you go all the way up until you reach the apex, or the peak, or the maximum length of the segment. So this is C whatever, M whatever. That's a Bragg classification. So again, let me read this phrase for you. So you have to locate the anatomical GE junction, which is the level of the tops of the gastric mucosal folds. Avoid measuring from the diaphragmatic crura and hiatal hernia. So then you count the distance from the anatomical GE junction until the lowest circumferential extent of the columnar epithelium, that's C, and then you count the level of the maximal highest extent of the columnar epithelium, M, again from the tip, the top of the gastric folds until the maximal area. When you biopsy the area for parrots, at least they recommend 8 biopsies, must show the columnar epithelium or standard metaplasia. High definition resolution endoscopy and chromoendoscopy both may improve the detection of the abnormalities when regarding parrots, but this is not yet a guideline. Remember that the presence of eosinophils in the squamous epithelium with parrot is not uncommon, so don't be confused that this might be an eosinophilic esophagitis. You know, GERD itself might give you a number of eosinophils in the biopsy. Now let's move to the treatment. Actually, there is no medical treatment that we are aware of for parrots. We give PPI only if there is a symptomatic GERD concomitant with the Parrot's disease, and there is no benefit of higher doses unless you are treating grade C and D esophagitis. So we usually give PPI once daily in case that there is a GERD. Remember that anti-reflux surgery does not prevent cancer if the parrots have developed already. All right. Few things here regarding the management of parrots. That parrot esophagus itself is the strongest known risk factor for esophageal adenocarcinoma. And remember, forget about these numbers again. We stick with the most known numbers. The non-dysplastic parrots have an annual risk of 0.2 per year. Low-grade dysplasia is 0.7% per year. And high-grade dysplasia have 7% risk per year. And this is another poll question here, that there is no identified medication or measure can prevent progression of existing parrots. Don't be tricked in the questions with NSAIDs, PPI, or decreased weight or surgery. Regarding the surveillance of parrots' esophagus, this has been changing in the past couple of years, and now again this table has been modified and adopted from the AGA guidelines for 2015. Remember here that while with managing the parrot esophagus, you need to know that RFA and fluid dynamic treatment are the only two treatments that were randomized. Screening for parrot is not recommended for general populations. Remember that when you take biopsies, you need to have a 4-quadrant biopsies every 2 centimeters. Again, when you start the surveillance management here, if you don't have parrot esophagus, whether you have GERD or no GERD, there's zero risk cancer annually, so you don't need to repeat this EGD at all, unless of course you have a grade B, C, or D that you need to follow after treatment. If you have parrot esophagus, whereas it's long or short segments, you need to look at the dysplasia. Now, if there is no dysplasia with parrots, the risk again is 0.2% per year. You no longer need to do like before that you need to repeat the endoscopy after 1 year. No, non-dysplastic parrot, you follow these patients every 3 to 5 years. This is by ACG, and the British Society recommend every 2 years. For the non-dysplastic, you keep the biopsies as the usual, Q2 centimeters. With indefinite dysplasia, this entity, you re-EGD after PPI treatment to see if you heal the esophagitis or whatever, and you repeat the endoscopy after 3 to 6 months, and you do here 4-quadrant biopsies at 1 centimeter interval. If there's no dysplasia, that's it, we're done. You repeat the endoscopy after 3 to 5 years. If again there is no, it's indefinite dysplasia, you do an EGDQ 1 year until there's no dysplasia by 2 years. If the parrot is dysplastic, low-grade dysplasia or high-grade dysplasia, first of all you need to confirm this by a second pathologist. If the pathologist confirms to you whether it's a low-grade or high-grade, the low-grade, you either bring the patient after 1 year for biopsies until there's no dysplasia for 2 years, or you do an EMR followed by an RFA, and this is the best way to manage. After that, you continue with Q6 month for 1 year, then yearly. For the dysplastic, for high-grade dysplasia, parrot esophagus, it depends on the feature of the high-grade dysplasia. If it's nodular, you go ahead and do an EMR, and it's superior to keep biopsying the patient, and it's comparable in results to surgery, and you follow this with RFA. If it's a flat segment, you go ahead and just do radiofrequency ablation, and it's better than the photodynamic circulation because of there's a high risk of recurrence more than with the photodynamic circulation, and more stricturing disease. After you're done with this, you bring the patients with 4-quadrant biopsies, Q1 centimeter, Q3 months for 1 year, then Q6 months for 1 year, then yearly. The other option is which actually we were not, it's not favorable right now, is that you send the patient for surgery if he has a high grade dysplasia for segmental esophagectomy, and actually these points have no longer been questioned on the board because they like a lot the RFA and the EMR. Last thing I want to tell you that you need to memorize the numbers here regarding the annual risk, and remember this is another board question. EMR and RFA after 3 years eradication rate will be 71%.